Okay, welcome back to the Aligners Intensive. This is a course that we are now in the third webinar, okay? And I'm very pleased to be here with you discussing advanced biomechanics and adjunct therapies for aligners. My name is Daniel Ramos, for those who are joining us for this webinar only. I have been with OIGS team for some time. Last year we did another course about the basic biomechanics from A to Z for aligners, and now we are in the next step in this course for more advanced techniques. Okay, so be sure to take a look there if you want to check all the other courses. I am orthodontist for more than 20 years and I am faculty in some institutes. I'm working at Spain, Madrid, as the orthodontics clinical manager for the ESD, doing a lot of treatment plannings for aligners. And this is where I am catching all the information, the cases where we are going to discuss and present to you with a lot of tips, okay? In this first two webinars, we talked about the main concepts, the most important information you need to know to do a correct diagnosis and treatment plan in the webinar number 1. The webinar number 2, we review the most important biomechanical rules for complex cases, what you need to know to solve a difficult case, to achieve a difficult movement. We're going to keep using these concepts in the next today's webinar and the next webinars, okay? But now we are going to go more specific about these adjunct therapies that can really improve the predictability for aligners, okay? What are the technologies we have available? How can we best use them? And probably one of the biggest game changers in orthodontics is Skeletal Anchorage with TADs, with mini screws, mini implants, all the same, okay? TADs is for temporary anchorage device, or mini screw or mini implants, are a great evolution in our specialty, right? We can do much more now that we could do before, and this slide I presented last class, and I'm going to use it for us to remember, right? In the previous diagram for what we can achieve with orthodontic movements, before we had skeletal anchorage, with orthodontics alone, we could only navigate inside this pink area here, okay? Intrusion, extrusion, retraction, preinclination. It was very limited, okay? Because we have a lot of limitations only with orthodontic appliance. We can increase a little bit more when we are dealing with kids, right? Growing patients in the yellow. But after this line, only with a surgery, we could solve more complex cases, right? And the use of skeletal anchorage helped us to bring to these limits, to surpass these limits that ortho alone and ortho with orthopedics can do. And this is very important for us to know, okay? Another important chart here, an important table, is this one. This is a very clever article that summarizes what movements are more predictable and up to what limit, right? Moderate, difficult movements. So it's really important for us to understand where we are, to understand if we need to use TADs or not. For example, I'm going to put bigger later for the example we are going to use, but for intrusion, when we need to intrude posterior teeth, up to 0.5, it's predictable. So probably not a case you're going to use TADs, right? But if you need to intrude more than 0.5 and more than 1 mostly, then I consider the use of skeletal anchorage mandatory, okay? So understanding these boundaries, these limits, it's going to facilitate a lot the process for you first to diagnose and then to recommend to your patients the use of this tool, okay? So we are talking about one of the most important fundamentals concepts for biomechanics with aligners, and not only aligners but basic orthodontics that We need anchorage to move teeth. Okay, this is physics. We need to provide some support, so the force we are implementing, it's going to move teeth to where we want. Otherwise, it's going to be a mess, right? So have a good point of anchorage facilitates a lot us achieving the movements we need. Okay, so this solution is related to this topic. Anchorage is needed. Okay, we already discussed in the previous webinars that overcorrection is important. Okay, we need to open space, we need to understand what aligners can do, but this is something that is referring to orthodontics with braces, with aligners, with lingo braces, anything. We need anchorage. Okay, so the skeletal anchorage is something that you should really invest your time to learn how to use, how to put in practice in your patients. Okay, I understand that for most doctors, when they are not using yet, the image of inserting a mini implant, a mini screw, it's not something that orthodontists they like. Okay, because orthodontists we are used to do more non-invasive procedures, right? And okay, there's not a problem there. Okay, but we need to face it that this is one of the less invasive, the most conservative surgical procedures we have. Okay, and the risks that we are going to review today, they are perfectly and easily controlled. Okay, because they are with the technology very easily detected how to overcome these limits and provide a good insertion of the TADs in a great position, okay, ideal position for what we need first, and also in a safe area, far from the roots, far from any anatomical important structure. Okay, so this is something that we need to check first. Okay, so just for you to know, when I start using this kind of technology, and here you're seeing one of the most used sets of configurations of inserting TADs for intrusion. Okay, we're going to review later. I did the procedure only checking an X-ray, checking the anatomical surface in the buccal side to insert the TAD between the roots, and sometimes we lose a TAD, sometimes we don't. Okay, and it was considered normal to do this. Okay, it was normal to just insert a TAD, and from each 5 one that you inserted, one you can lose, and this is what happened. And I wasn't satisfied. I was not satisfied with these statistics, right? Because every time after I convinced my patient to insert a TAD and it failed, it was me failing there. And I don't like this, and I don't think it's fair for the patient, although it happens. Okay, so I invested a lot of time to research how can we avoid this, how can we reduce these risks, right? How can we increase the chances for us to insert a TAD and this structure, this device, this screw to stay there from the beginning to the end of the treatment or until we need them. Okay, and the first thing that we need to ask is, before we do this procedure, how to improve the success rate. Okay, although 80% is a good number, right? Any kid in school will pass to the next year with 80%, but when we are talking about a patient, when we are talking about patient's health and a treatment that he's paying us, sometimes, in my opinion, is not acceptable. Okay, so the first thing we need to understand, and again, I'm just using one article as an example, but this is something you can see published in several articles over the years, okay, about the most important factors that can influence and cause a mini implant to fail. Okay, and the most important ones are related to patient's age. Okay, so we know that adult patients, they have less bone density than younger patients. Okay, so sometimes for adults we need to evaluate how is the bone density, and this is something that in a CBCT, with the softwares you have, is something easy to check, okay? So a patient with good density has a better tendency, a better chance to have a more stable mini implant, okay? So this is something for us to consider. The location, okay? The problem is not contacting a root, right? Because several articles also prove that even though we are touching a root, after we remove the TAD, there is a very good chance for this root to heal well, okay? The problem is to place very close to a root or contacting a root, and this is going to cause instability for the mini implant. And during the ortho movement activation, we are going to lose this screw, okay? So this is something we need to consider, where we are going to insert. And the third factor that it's very important for us to check is how much we are inserting inside the bone. The mini implant selection, the length we're going to use to insert inside the bone, because we need to have at least 50% of the screws inside the bone, ideally. Only if we are inserting in a cortical plate, like in an extraovular area, that we have bigger or thick cortical plates with the biggest thickness, right? Bigger thickness. So maybe we can have a better stability. But if we are inserting between the roots, where the cortical plate is very thin, and we are going to insert the biggest part of the screw inside the alveolar bone, the trabecular bone, if we insert less than 50%, we are going to promote forces in this mini implant that can create instability and failure, okay? So these three factors, we can control two of them, okay? Because the age is the age of the patient. We cannot change, unfortunately, right? But where we are inserting and how deep we are inserting, this is something we can easily control. And how we can do this? By eye percent, just looking to the patient, looking to an X-ray and inserting the best we can with our experience. Not ideal. It's much more honest to the patient nowadays to use the technology we have available, and this is what I am defending today. And this is something that is going to facilitate significantly your beginning using this technology. Even for those who are experienced by placing by freehand, without any CBCT assistance, without any guide, okay? I believe these concepts I'm going to share will bring more information so you can convince yourself to start using these technologies, okay? So, the problem, then the risk factors, okay? Root proximity, when we don't have enough cortical plate to stabilize, and a small amount of screw inside the bone, okay? And this example, this happened, right? Because we don't have much area, although we are talking about a buccal shelf area, okay? By checking the CBCT, because this is a case of mine, and I'm using it for you to learn with my mistake in the beginning when I start using, okay? I placed using the ideal technique that I was learning. I did a lot of courses with some colleagues more experienced than I some years ago, and then I started doing after I was confident enough, right? And then today I have my casuistic. And for this case, although I was using the ideal TAD long enough, although I was placing an area that we have enough bone, by not inserting enough inside the bone, by not checking the CBCT before, and not maybe selecting the ideal area and guiding this, I lost this TAD. Because, look, just a minor amount inside the cortical plate, okay? Another situation that happens if we are not using technology. In this case, I was saved by technology, okay? Because I was planning this case, the ideal smile design, we can see here in white, we were test driving his face, we detected the need for intrusion in the posteriors, okay? We move on to the clean check. This clean check is being guided by the design. You can see here the model. Let me fast forward here. Okay, so this is the design, and I need to intrude this posterior, mostly the molars, so I can also correct his cant, this inverted curve, and this is something that later he will receive restorations. This is not the topic for today, but the thing is, we needed to intrude posteriors, and the whole idea is to use these biomechanics here, placing one TAD in buccal side, other in the lingual side, and placing the elastic from one to the other, passing over the aligners, okay, using the aligners as a support so the elastic can make this intrusion force and help us to achieve this amount of intrusion in several areas, okay. So this is something that, looking to the panoramics, we have a lot of space between the roots, okay. One thing caught my attention when I start looking to this case. The sinus is very low, okay, so we need to understand if the sinus, we have enough bone to insert the TAD between the ideal area, which is between molar and premolar, where we need to actually intrude the posteriors, okay. In the left side, we have a better chance here, but here, very low sinus, so this is something for us to check. In the past, I would only use this image and looking to patient's mouth and all the anatomics in the buccal surface, we can check that we have a lot of space between the roots, okay? But this is the kind of case, if I try to insert without any guidance, I would fail. And this is a case that we did here with DST, okay? We did this TAD analysis where we are going to virtually place the TAD before any treatment, okay? And when we start doing this, we start trying every area here between molar and premolar, between first molar and second molar, and everywhere we tried, or we were invading the sinus, as we can see here, or we were not inserting enough or contacting a root, as in this other option here in this other area. Here we were pretty much in the crest, the marginal crest, with not enough bone to stabilize and very close to the roots. So this is the kind of case that we, by doing this analysis, we understood that TADs for this patient weren't the best idea, right? Because we don't have actually space to insert them. So this is the kind of case that we may need to think on a mini plaque, okay, more invasive, or we are going to use sequential movements over correction and more time with aligners to solve this intrusion that we need, okay. So here, if I try to insert the TADs, I would fail, as the other case that I didn't made use of this analysis with the CBCT, okay. So for intrusion, problem is the situation that we use these mechanics, this adjunct therapy, the most in my experience here, okay? Mostly for posterior upper intrusion, where it's tough for us to achieve this movement, and it's very important for the aesthetics of patient smile, right? Because sometimes we have the canted arch, we have an inverted arch, so we need to intrude to achieve aesthetics, and this is something the patient will demand. So it's an important movement that is very, very often necessary for us to solve cases. So today, in this lecture, we have only 1 hour. I will focus in this, the two most important moments, most important situations that we need to use TADs, okay, for upper posterior intrusions and for distalizations of the posteriors, okay. These are the situations that we can use 2 different techniques, and I'm going to use some cases for us to exemplify, okay. This is a very beautiful case that we did in partnership with several dentists and orthodontists and surgeons. This is a comprehensive case for a patient that she has a lot of necessities, right? Talking about ortho, after doing all the process that I exemplify in the first webinar here, by creating this design, using the face as the reference, creating a virtual mock-up and testing the mock-up, we diagnosed the need for intrusion in the posterior arch. Okay, so this is a case from Dr. Jesus Crea. He's a doctor from Spain, Seville, a friend of mine, and we did this case together with the DST team. Okay, so this is the initial files. We have here, although we look not a very bad intercuspation, but in her face we start seeing some needs. Okay, so she already had, when she got to us, implants in the posteriors. She lost here, these molars extruded over the years. Okay, by placing the frame, and the frame is very important. More and more the softwares that you're going to use to plan your orthodontic cases with aligners, they're going to come with this tool. Okay, so this is something that is universal. Although the EST here uses for several years and probably was created by us. Okay, you can see these tools in several softwares to plan ortho, to plan restorations, to plan prosthetics, to plan implants, because we need to understand that in the end we need to have an outcome that is according to the face. So here we can create this smile curve that needs to be according to the lower and the upper lip. Okay, the proportion of the centrals in this rectangular box. Okay, the gingival margins, the papillas, the midline. So this is something that only by doing this we can now check that this molar is more extruded, is coming out of this green line. Okay, and of course testing her face, doing a mock-up. This is more advanced because this is a mock-up, a test drive. Okay, we can also check if it is good or if it's not. Okay, to see if the patient approved this. Okay, so this process of simulating, test driving is the beginning of every treatment. You should do this for all your cases because it's much more secure, it's safer for us to make the decisions after test driving the computer. Okay, so this design here was approved by the patients and by the interdisciplinary team. Me as orthodontist, I checked the occlusion and I like the intercuspation, I like the midline, and we have this color code to facilitate our communication. Okay, where blue is ortho plus restorations, molars here it's green only ortho, red the implants only restorations, and this is something that can facilitate a lot our communication from the team to team or with the patient. So here the patient is before and the mock-up. Okay, so she can visualize our idea how we plan that is going to be in the end. Okay, here in the mock-up we can adjust the color, we can adjust the cant, we can make the corrections, so she can have this frontal visualization that can generate a good idea or what we are planning to her. Okay, so this is a way to have the patient participate in this process, and they really like to do this. Okay, it's like a test drive when you're going to buy a car, or when you want to buy an apartment, you are going to see the decorated apartment, so you can imagine yourself there. Okay, a lot of companies, they use this technique to increase the will of the clients to buy stuff. And here it's not for us trying to convince or deceive patient. Actually, we're just trying to make them see with their own eyes what is the ideal treatment for them. Okay, so this is a good thing. We are trying, I don't like to use the word convince. I like to say that we are helping patients to see with their own eyes. Okay, what we as a specialist team understood that it was the best for her. Okay, so by doing this, and after the patient approves, the moment is to proceed for the treatment. Okay, to the treatment, and we are going to use this design as our guidance. Okay, so this workflow we have been using, and more any aligner company is using this, is to use the same design that we approve with the patient, the mock-up, and we approve virtually here to guide our movements. Okay, and when we have to intrude, as we can see here, let me play again, we are intruding the molars, right? This kind of intrusion, when we need to do more than 0.5 and mostly more than 1, activates here our protocol to indicate skeletal anchorage. Okay, so we use a lot, and this study that I present to you helps a lot to make us clearly understand when we need to implement and use TAD. Does it mean that we are going, by using TAD, we will avoid all the other strategies that we already discussed to promote a more predictable movement, considering intrusion? My answer is no, okay? I want to add and not to substitute. So what I want to do here is to keep using the overcorrection of the posterior intrusion, and I like to use the 50%. So if I need to intrude 1 millimeter, the molar, I would intrude in the software 1.5. This overcorrection will improve the force system for us to achieve a better intrusion. When we have several teeth in a quadrant intruding, we need to do sequential movements, okay? Because if we try to intrude all at the same time, even using skeletal anchorage, we are going to lose predictability. So even if I'm going to indicate to my patient the skeletal anchorage technique with TADs, I still am going to plan my clean check using these strategies of sequential movements and overcorrection, okay? So here the case that we are discussing, let me click here, okay, pause, the clean check, I'm going to look that the second molar is intruded, starting the movement before, just after the first molar. When the second molar achieves the final position, we start moving the second premolar. But now it is stopped and then it's being used as anchorage. Okay, the sequential movement is very important because we always have more than 2 or 3 crowns being used as anchorage while 1 or 2 crowns are moving. Okay, crowns not tooth, right? When no moves on the crown. So this strategy is going to improve the predictability of the movements we need. Okay, this sequential movement. Go back to the previous webinar and explain how to order this, how to order to the technician. This is something you need to write to the technician, but you need to explain and detail this. First, intrude tooth 1.7. When it achieves 50%, start intruding 1.6. You can repeat these, or depending on the technician there in Costa Rica, he will understand if you just mention, use this protocol for the other teeth in this quadrant with the 50% protocol. Something like that, and it's going to work fine. Okay, but what I want to say here is that by using the TADs, which is an amazing anchorage system to achieve this intrusion, because you can see here, right, that from this TAD to the other, this elastic is going to create a very vertical intrusion force. It's going to make the aligner go up, right, because we're going to use the aligners. This kind of biomechanics, this elastic needs to be only inserted by the patient when he is with the aligners in his mouth. This is very important, okay? So again, normally we think about ideal position, but then we need to check not only the panoramics. Let's go to the CBCT. And with the technology we have today, the possibility of us segmenting all the roots and seeing the root in the initial position here in yellow, okay, and in the final position according to this design, blue, in green, we can place the TADs in a position that is not going to contact at any moment of the treatment, okay, not only in the beginning but also considering the ideal final position. So with this approach we can solve one of the most important risk factors for us to lose a TAD, okay, the location. The second, we have here in the information, the same software. We can actually see how much we are inserting and insert as much as you need in a safe position to not touch the root, even in the final position. So we can have this TAD very well inserted, like we can see here bigger, okay? So we have more than 50% of the screw that comes from this line to the point, the tip of the screw. So we have more than 50%. The number here is right in the middle, okay? So, and we are not touching the root, okay? And the root in the final position. So this is something that makes us to sleep much better at night, knowing that we are going to do this technique with the guide is going to be very fast and in a good position, okay? Then after we understand where is the ideal position. Sometimes we start thinking about placing between molar and premolar, and then we test in other areas so we can have a better distance for the roots, or the TED more inserted inside the bone. In the computer, it's easy for us to make mistakes and go back. In the patient's mouth, we cannot do this, okay? So let's try here in the computer. Let's try all the possibilities. Needs to make sense with the biomechanics we need, okay? And here we are, understanding that this solution with one between molar and premolar in the lingual side, and in the buccal side from the second molar to the first molar was the ideal, exactly what we need to do the intrusion, okay? And after doing this, we can virtually create this guide that later, here is just for educational reasons, of course, we don't print the model with the roots for every case, just to show the roots and the TEDs there far from the roots. Using the guide with this stop, we can see a stop here that is going to indicate where you need to stop inserting, okay? And here the procedure. You can use the manual driver, the contra angle, which one you prefer more. My opinion, I like to use the manual driver, okay? With the manual driver, I have more control, I feel better, the resistance of the bone, I know the velocity I need to rotate, okay? And if the patient is feeling some pressure, I control faster to stop, to check, okay? With the guide, one of the most important tip is for every guide you're going to use. Doesn't matter if it is a guide to insert TEDs or if it's a guide to do crown lengthening or to place an implant, you need to keep the guide there steady in position from the beginning to the end. Imagine here that we are dealing with a very restricted area, right? We don't have much margin for deviations. If we deviate a little bit the guide, we delocate a little bit, we are talking sometimes less than 1 millimeter, but this is a lot when we're talking between the roots, okay? Here we have the TEDs inserted exactly in the position we plan, okay? Very close to the cervical line, and this is good for the patient because it's easier for the healing, it's easier for the patient to insert, and again, we can only do this by doing virtually first, because otherwise we will try to always to move higher so we can be in an area where the roots have more distance between one to the other, okay? So this is something we can only achieve, this quality of insertion, using a guide, in my opinion, okay? Another advantage of a guide, sometimes we are tired there in our clinic, sometimes we are not in our best day, and then we may insert not in ideal position for one patient, okay? And why this patient needs to receive this? By using a guide in this analysis, you can be sure that you are going to insert with the same care, with the same quality for all your patients. And this is something that, this information, your patients, they're going to love to hear, and they're going to spread this word, okay? My dentist, he's concerned about me, he's using this guide to be sure that he's not going to create any harm, and you can be sure that this patient is going to refer other patients, okay? And here inserting the elastic, okay? So take a print screen here if you want. Remember this position of these TEDs. When you need to intrude posterior teeth in the upper arch, this is the best biomechanics you can use. And I'm talking here after the past 2.5 years, almost 3 years, in front of the DST TPS, doing more than 2,000 cases, complex cases that we referred a lot of TEDs, I can say to you that really works, okay? In this case, for example, we need to intrude more or less 2 millimeters, okay? And this is the quality control. This overlapping you are seeing, this transparent orange and this kind of salmon color, right? This is the initial position and the final position after, the actual final position after using. It's not a simulation that we did. This is after 6 months. During the first set of aligners, we could intrude all the 2 millimeters we needed. So by only adding this, that is super fast, the patient was super comfortable about the procedure, didn't bother her at all. After we could solve the most complex and challenging movement in the first set of aligners and only in 6 months. Okay, so this is amazing, because normally we will need additional aligners and more overcorrections and more stagings to achieve this without TEDs, and sometimes we cannot achieve if the patient is not collaborative. Okay, and this is something, of course, the patient needs to insert and remove the elastic, but as soon as they realize that they can achieve such an amazing outcome in such a short time, this is something that they really get on board. Okay, so the quality control that we do, we are overlapping what we plan here in green. Okay, this is the ideal outcome, and this is what we achieved, very close. Okay, so in the frontal view we can see a lot of orange teeth moving out in the vertical here, the ideal in green, and here, although they are more expanded, which is not bad, we could intrude enough so we can level by the design here in the incisal edges. Okay, so we solve the issue, the lower arch. The lower arch is not the topic for this case, and here, after the first set of aligners, the patient was going to do the restorations she went for. Okay, this is a patient that looked for the treatment to go for veneers. Okay, and this type of patients, most of the time, they are not doing ortho. Okay, because by not doing these simulations, sometimes it's not that the dentists don't want to do ortho, but because they cannot show the advantage of doing ortho. And the best way for us to do this is by doing simulations so the patient can visualize. So this patient accepts the ortho with TEDs, so she can go finally to the restorations. Okay, and here is a very interesting slide just to exemplify that we can guide pretty much everything. Here we are using this guide to understand the crown lengthening, how much we should remove from soft tissue and bone, so we can have a stable outcome for the crown lengthening. This other guide is guiding the preps, okay, how much we need to remove. So it's all the preps are guided here, so we can remove only the necessary amount, so the veneer is going to have the same thickness and it's going to be stable. Okay, and here again, here the patient is numb, is anesthetized, so she's not contracting her lips for this final. We need to have another one, but we can see initial, after ortho, before preps, with the provisionals, okay, and the final. Okay, everything according to the plan, everything guided and fast and predictable. Okay, and of course this is not my job only. I was one piece of this engine here with a lot of dentists, an interdisciplinary team, lab, and the most important thing, the patient happy. Just for you to have an idea, today with the digital, I am working here in Spain, Madrid. Sergio is an oral rehabilitator from Brazil. He was in Seville during the course. Mauricio is from Uruguay, here from Brazil, Spain. A very international team working with the digital and only getting together to do this procedure for the patient. Okay. We have a lot of doctors nowadays using the guides and using more TEDs because of the guides. Okay, this is very safe for us to implement and can increase a lot the success rate, what we started discussing today. Okay, so this video I received from a good friend of mine who works in New Zealand. Okay, and he's a good client here from DST, and he is an experienced surgeon. So he wrote to me after doing the procedure. I asked him for a feedback. So he started. Initially, it's important to say that I've placed many TEDs by freehand. Okay, so he was used to do this. Okay, so it was his first time placing with a guide. So he commented, I felt more confident and comfortable knowing that the guide provides the TEDs placement precision, what we discussed, right? Location and how much inside the bone. My major concern was to have the guide well positioned and stable, and this is something that I really encourage you to always do. Any guide needs to be very well positioned and stable. So he noticed when the patient beat against the guide, there is no chance to to move position. So we recommend actually, so the patient needs to bite the guide, so keep it stable and help you during the procedure. Okay, so the procedure went smooth and the patient felt well surprised with how quick and pain-free it was. Therefore, I highly encourage you and this team to go ahead. We were in the beginning of this project. Okay, so the most important features, it make it simple, this procedure. Okay, so it doesn't need to be a surgeon to do this. The orthodontist can place very fast, and ideally recommend that you test drive before and use a design to guide this solution. Okay, here you can see the patient there with the TAD, and only for intrusion? Of course not. Okay, I mentioned in the beginning, we are facing here two situations where we can really use tests to improve predictability. One, I just use the example of this case to exemplify to you the posterior intrusion, okay, and show to you a good way for you to promote posterior intrusion with a great predictability. Okay, the second situation, when we have big distalizations, we need to correct a big class 2, or we need to open space for to correct roundings. Situations like this one, okay, that we can avoid extractions by using this technique. Okay, so in the past, cases like this that we are seeing as an example, most orthodontists would extract 4 premolars. Nowadays, more and more, we are seeing amazing outcomes without any extraction, and most of the times we need to use TADs. But what is the challenge here? Since we need to distalize, to place between the roots, it's not a possibility, right? Because we won't have, the TAD itself is going to create a barrier there for us to distalize. So we need to find areas where we are far from the roots and we open space for these distalizations, okay, in the upper or in the lower arch. So where we can insert, we have these letters here, the infrazygomatic crest in the upper arch and the buccal shelf in the lower arch, okay, are great places for us to insert. So again, let's go back to the studies, to the articles, the same article there. For anterior posterior correction with aligners, okay, up to 2 millimeters, it's predictable. So here, if we have to distalize only 2 millimeters to open space, to correct a class 2, to improve the occlusion, this is not the case. You need to use skeletal anchorage. Okay, I start thinking about skeletal anchorage when I have more than 2 millimeters. Okay, but most of the times I'm going to use skeletal anchorage, mandatory when we have more than 4 millimeters of distalizations. Okay, anterior posterior movements. So this is the kind of situation that without TADs, it's very difficult to achieve. Okay, and again, the same way for the intrusion, I won't eliminate the need for the sequential movement. Okay, that we discussed in the previous webinar. With the sequential movement, we are going to increase the predictability of the system that we are implementing, the 4 system we implement with the plastic, and with the TADs, we are going to increase the anchorage system, so we can avoid that while we are distalizing molars, for example, the anteriors procline, and then we need more time and more additional liners and lose outcome, so we need to repeat and go back. So this is something that, my patients cannot accept anymore. Okay, so it's simple. It's something that anyone here can use by creating protocols, by using technology, by using guides. So here, just to exemplify how we use. So some information, okay? When we are talking about the infrazygomatic crest, we need to understand that this is a small area between the first and the second molar in the upper arch, okay? The ideal inclination is kind of 30 degrees here, okay? Between 30 to 45 in this yellow area, okay? And our goal is to use this cortical plate as an anchorage, a very dense bone that can, even though we are not going to insert 50% of the screw inside most of the times, because it's a very dense cortical plate, it can be stable. Okay, so some anatomical knowledge is important here if you are going to do by freehand. Okay, and most of the times by freehand, there is a technique that you need to use that you cannot start inserting in this angle. You need to start in 90 degrees to avoid any accident, to slip, some slippery of the tip of the TAD, or to hurt the patient. So it's a very sensitive technique. So the guide simplifies a lot this procedure. Okay, so I highly recommend you, but most important, to really understand where you can place. Okay, one good information. I really like Chris Chang articles and studies. Okay, Dr. Lin and Dr. Robert, they have amazing studies pretty much about everything, and we need to take a look on what the masters are saying. Okay, so the Chris Chang did a study, okay, to evaluate the success rate of the infrazygomatic crest bone screws. Okay, so he talked about patient's age, the angle, and the sinus penetration, which is one of my biggest concern because we don't have much space. Okay, so here he is reviewing this article. You have the QR code here later, but you can look for the American Journal of Orthodontics. Okay, this is a very recent article from 2022. Okay, he is describing the kind of TAD he's recommending. He has his own brand, which is very good, but there are a lot of other companies, they are selling this kind of TAD. So, but here is interesting because he is defending some important design in the TAD, because here he needs to have a good and important head, so the soft tissue won't swallow the TAD, because it's an area we are open, closing bite, and there is a lot of soft tissue, right? Needs to have 12 millimeters, in my opinion, at least. Some cases 14 millimeters is not bad. Okay, a sharp edge. Okay, stainless steel ideally, because titanium, since we are not inserting enough inside the bone, sometimes they can create some deformation. Okay, but about the sinus, he diagnosed that a lot of cases, by not doing the simulation, he invaded the sinus with the TAD. Okay, and what are his conclusions when it's happened? Okay, the incidence of sinus perforations increases with a more upright insertion. The higher, right, the more chances we have. Okay, and also in adults with more than 30 years, where they start to have a lower sinus, less bone, less density. And one of the most important information here, sinus perforation, they concluded, is an acceptable complication for 2 millimeters diameter TADs, because it has no significant effect on TAD survivor, and the patient didn't relate any sinus problem later. Okay, so this is something for us to have in mind. Okay, but with the possibility of us planning in advance in the computer, we can avoid for sure. In the buccal shell for the lower arch, again, even a smaller area in this green, okay, which is kind of a plateau in the bone, that we have a lot of dense cortical plate here. Okay, so by looking this frontal view, we can see that it's like a very vertical area, and then there is a horizontal area. It's like a shelf, right, where we put our books in the wall, right? And also a great area, so we can insert the TAD very vertical, okay, and far from the roots. Again, the important. Look here in one of our cases how the TAD was, okay, so very vertical and a lot of bone. So it's a very safe procedure, and if we can simulate before, even better. Okay, so here by placing the TAD virtually before, we can check how much we are inserting. Okay, we can check how far we are from the nerve. We can check how far we are from the roots. Okay, so this is something that we can go slice by slice there, just checking the position. And by doing a design, by having a design that can guide us to understand where is the final position, we can see in 3D if this tab that we are inserting is going to contact from the orange to the green, initial to final, the roots in any moment of the treatment. Because as the first case that I presented here, my mistake there, that I didn't consider the final position, and it started the roots to get close and I lost the tab, we can avoid this, right, by doing these simulations, okay? So this is something that more and more you have available. All the softwares that you use to work for your aligners, providing this kind of information, the CBCT, the roots, you're now having tools for the design. We do this here in DSD for you to review the case even before you start any treatment, okay? But you don't need to use us to do this, okay? Just look for a company, just look for a system that can provide this kind of information, okay? And by doing this simulation, by placing virtually later to place a guide and to create a guide is easy, right? It's just a process of making sure that the instrument you're going to use is going to be accurate to insert exactly in this position, okay? So it's something that needs to be tested. We tested a lot to develop the guide in a way that is going to be very efficient to use with a driver, okay? Depend on the brand, depend on the type, we need to have someone that we use. It's important to have this window here so you can always check how deep you are, because ideally you shouldn't remove the guide only when you finish inserting, when they ask you to stop rotating, okay, to start driving inside. We call this monitoring gap. And the benefits for the guide, for sure you're going to place in the best location. For sure you're going to insert the biggest length of the tab inside the bone. For sure you'll be far from the roots, okay, and safe. It's a very smooth procedure. There is a lot of time saving, and it's going to stabilize the position, avoid any accident during the procedure, okay? So I receive a lot of feedback from a lot of doctors. They cannot do this procedure anymore without a guide. So I really encourage you to look for a partner or for you to use a software that can help you manufacturing these guides. If you're asking, the software that I am using here is Nemotech, okay? It's a very complete software that is available for any of you to buy and use in your clinic if you want, okay? And for us to finish today, I would like to use, of course, a case to exemplify this technique. And this case, it's, let's say, a complex case. We are dealing with complex cases in this course, right? So this is a case that we discussing as a planning center. We were doing the plan for this case with the doctor, and this patient want to avoid at any cost extracting teeth. Okay, and I agree, and I think it's possible, although it's not wrong if you say, okay, I would extract in this case. Not wrong, okay? But this patient has airway issues. We didn't want to reduce the arch perimeter, and he was open for a long term, for a marathon here, okay? There is a secret ingredient here that we are not seeing, that something that is going to be solved later. He has an impacted cuspid here in the upper arch, the 1.3. So we did out a study for us, not only open space distalized, but also to open enough space to make the cuspid traction in the second stage, okay? So the plan and the design that we are aiming is to, the only extraction we will need to do was the third molars, okay? And then we would distalize pretty much the full crown, okay? The second molar will move to this position, okay, to the position of the third molar. We are talking about 8 millimeters distalization. So it is the double of what the study mentioned that is very difficult, okay, just for you to be exemplify what can be done with aligners and tabs, okay. The lower arch, the same. A lot of distalization, a lot of space that needs to be open, okay. Our target, our ideal is to achieve this occlusion in the end, okay, from here to here, okay. So the clean check, of course, not easy. We are talking about 80 aligners. Okay, 80 aligners is tough for the patient. It was very well explained. The patient understood. So here we are distalizing. Okay, and again, I'm not going to eliminate the good strategies. I'm going to do the sequential movement. Okay, so we can have more predictability even using the TADs. Okay, so here the TADs, if you remember, okay, they are placed in the infrazygomatic crest between the first. Let me go to the initial malocclusion here. Between in this area here, okay, we are going to place the TAD very vertically here with some angle 30 degrees between the first and second molar. The head of the TAD is going to be more or less in the gingival line, and we're going to use an elastic from the TAD to the button that we're going to bond here. The buccal shelf, it's from the distal of the first molar to the second molar, and of course here everything is mesialized, so may change, so we need to check the CBCP. But again, we're going to have the head of the TAD here, so an elastic can come from the arrow that I'm pointing here to the button here, and we also left a button here to use in a second stage. Okay, this way we are going to stabilize the anteriors to avoid any pro-inclination, and we're going to lock them there, so all the sequential distalization is going to, the plastic is going to force the posteriors back. Okay, and again, a lot of movement. You can see here that this is a big journey for these molars. Okay, one of the most challenging cases. This case is a little bit more than we usually do, but it was a challenge, and here we plan. Okay, we can see that we are looking for a place that is not contacting the roots and trying to insert the more we can contacting the cortical plate here. If we go to the traditional place to insert an infrazygomatic crest, we would maybe invade a sinus. Christian mentioned that it's not a problem, but by doing this and by checking the position here, we can really avoid this and place in a safe area and a stable area. Okay, and then manufacturing the guide. Okay, and the lower arch, the buccal shelf, the same thing. Look the amount of cortical plate we have here. Okay, with the guide, easy, right? And testing initial final position of the roots, all the process, so it can facilitate a lot us selecting a good area, good position, so the head of the TAD is going to be in the best angle possible for us to have the best anchorage system, and also the screw is going to be well inserted inside the bone. And here is our outcome. Okay, this is the initial. Okay, let me pause here. So we have this initial condition, and in the upper arch, what we achieve after one set of aligners. Okay, this is the scan after we finish the first set of aligners. Okay, so you can see the second molar here, and where we move it 8 millimeters, more than 8 actually. Okay, so this is before, and look, this is, in my opinion, I was surprised actually to achieve this in one set of aligners. This case, the patient, besides aligners and TAD, is important to mention, he used also the high frequency vibration device, the Vipro, that can also increase a little bit predictability. And this patient used dental monitoring. Okay, dental monitoring is a system so that we can monitor all the aligning changes and keep on track of everything. Okay, so here, this is the difference in one set of aligners. Okay, from the beginning to the end. In the lower arch, initial and final. Okay, initial and final. So the final occlusion after one set. Okay, very close. Look at the intercuspation. Now we are ready to the second phase. Probably we'll fine tune some movements, and also we start making the cuspid traction. Okay, and again, TADs can be very useful, because if I place buttons in this tooth, this one and this one, I may extrude more than I need, and we'll lose this amazing outcome. So normally, to do the cuspid traction, this is the next chapter spoiler, right? I would place a TAD here, so we can use this TAD to make a very vertical force to move the cuspid down. Okay, so here we have the other side, a greater outcome to such a complex case. Okay, so 80 aligners, extravelar TADs, Vipro and dental monitoring, midline great, the intercuspation great, the space for the cuspid very good, the shape of the arch is surprisingly good for one set, and without any extractions. Okay, so this kind of case make me say to you with all the trust that TADs can make it possible, and without TADs we will never achieve this outcome. Okay, so guys, for today this is the message I would transmit to you. Okay, since we had 1 hour, I selected the 2 most important skeletal anchorage strategies for us to improve predictability. And if you control these 2 technologies, these 2 techniques, you pretty much you are going to solve almost all your complex cases, right? Because for any other movement, we can adapt with the aligners, and TAD is not so important. But for distalizations like these and for intrusion of the upper posteriors, you really need them. Okay, so by understanding this, I feel that you are 1 step closer to avoid extractions, to promote better treatments, and by using guides, you are going to feel more confident about recommending these to your patients. Okay, in 2 weeks, our next webinar, the number 4, we are always halfway now, right? I'm going to start talking about one of the topics that I am really passionate about, which is bone modulation. Okay, accelerated orthodontics and bone modulation. I've been working with this for a long time. In Brazil, I was the clinical director for Propel Orthodontics, who developed the micro-osteoperforations and the high-frequency vibration, and I had a lot of cases to share with you. And although I already mentioned these techniques in some moments during the courses, I would like to go deep, explaining to you the benefits, the biological principles, showing cases. Okay, so I split it in 3, okay, because this is a cool topic and I feel that we have a lot of information. So the first part about accelerated orthodontics and bone modulation, I'm going to talk about a very simple, non-invasive, non-surgical approach that can facilitate orthodontic movement. Okay, and this is something you can start using tomorrow if you want, or in 2 weeks, let's say this. The number 5, the webinar number 5, I'm going to discuss the technique of micro-osteoperforations and some adaptations that we can do to achieve better bone remodeling process and faster movements. And the webinar number 6, the third part of the bone modulation and orthodontics, about a more comprehensive technique that we call SFOT, surgically facilitated orthodontic treatment with cord economies. Okay, and when we are going to use them and why it's important and what we need to take care to be very accurate doing this surgical procedure. Okay, finally, if we're talking about complex cases, we cannot miss the opportunity to discuss orthogonatic cases with aligners. And I'm going to finish about probably the most trendy topic now in orthodontics, which is this collaboration between restorative and orthodontics aligners. Okay, we have now Invisalign launching the Smile Architect. We have another companies using Smile Designs tools to guide. And how can we use this and how can we achieve better outcomes adding the restorations with orthodontics? Okay, so I hope to see you in the next webinars. We have a lot of content to share, and now I am available to any questions you may have. Okay, be sure that if you don't have time to make the question today, to contact the OIHS team. They are great. They are going to provide all the support and they're going to forward the questions to me. Okay, so at any moment during this course I will be open to answer to you. And if you are seeing this webinar later in the recordings, again, be sure to make the questions and I will be very glad to answer. Let's see. The OHS team is typing here in our chat. Let's see if we have any questions. no questions by now, let me take this opportunity to invite you to go there in my Instagram, Daniel Ramos Orto with TH, okay? Follow me there, and then we can contact, we can chat, you can make questions, you can see what I'm planning, courses, the next course here, cases that I'm posting. So be sure to be there so we can keep in touch, okay? But of course, the questions related to this course, it's much better if you can do directly to OAGS team, okay? So they can refer to me, and then it's going to be better. So no questions so far. Don't be shy. I hope this topic provide you valuable information so you can be sure that it's easy to use and you can start using. I can for sure help you on any tip, okay? Probably the most important is to find yourself or a good software or a good planning center or even a good company that can provide you these solutions, okay? So one of them, okay? I know a lot of doctors, they are doing the guides by themselves using a software like Nemotech or even Nemotech, okay? I know doctors, of course, because I work with DST, that are using our planning center and we are working together in these solutions. But I don't think it's time anymore for us to keep doing the TADs by freehand with risks and with a low, in my opinion, success rate. So this is not acceptable in my opinion anymore. How we are, Valeria and OAGS team? Do we have any other questions? Can we finish for today? I'm up to you guys. Okay, we'll be here organizing my thing, and if we don't have any questions for today, hopefully you can do them later, okay? I'll be glad. Let's finish for today, and I hope to see you in 2 weeks for our next webinar. Stay safe and see you there. Hugs from Madrid. Bye bye.